Welcome back. At this time, I'm excited to welcome staff from CMS Innovation Center, or CMMI, who will share updates on the CMMI Serious Illness Portfolio. First, we'd like to welcome Dr. Suzanne Bernheim, Chief Quality Officer and Acting Chief Medical Officer, and Dr. Jacob Quinton, Medical Officer of the Patient Care Models Group, to share introductions for this panel discussion. Welcome, Susan and Jake.
Hello, I was going to say, I guess it's still good morning. Good morning. It's really nice to sit up here with all of you as I got to do last time. It has been an amazing first day and a little of conversations, and really a pleasure to be here with all of you. We have an amazing panel for you, so I'm going to be very brief, Jake and I, in our introductions, but we're really happy and grateful that the committee let us put together this discussion on some of what's been tested or is being tested in the CMS portfolio around payment models and demonstrations focused on seriously ill beneficiaries and those with complex chronic diseases. This is going to give you a little bit of information on many different pieces, so I hope we'll have time to get through all of it. We're going to start by talking about 3 models that have existed and what we learned through the evaluation of those models, and then we're going to focus on 3 newer models that are either have been implemented or will be implemented shortly, where we've taken some of the lessons learned and are thinking again about how best to design models to care for complex chronically ill patients. One thing I want to say that that sits in the background of all of this is that, as all of you know, the Innovation Center was given the authority to test new payment and service delivery models, and if they are found to reduce spending and maintain quality, or improve quality and maintain spending, they can be expanded. But there's actually also a lot of different ways that our models generate learning and get scaled, even when they are not formally expanded. And you'll pick up on some of that here today. So I just wanted to note that. In some cases, we learn something, and rather than scaling the model, we bring it into a new model. So I'm going to get the name wrong, so I'm going to look at my notes for a second. The ACO investment model is a model that we tested and then was brought into the Medicare Shared Savings Program, renamed the Advanced Investment Payment Program. In other cases, we bring lessons learned from our models into successor models. So you'll see some examples here of that today. I think I'm actually going to keep it at that. Let Jake go through a couple of these slides, but really our goal is just to give you some of the grounding in the work we've done in this area and the lessons that we have learned and continue to learn to try to build strong payment and service delivery models for this population.
Thank you so much, Susanna. And just 2 more quick slides to get us started, sticking with the goals of the panel discussion slide. Our panelists have been given the nearly impossible task of describing multiple years of work in between 3 and 5 minutes. So we're just going to give a quick snapshot today, and I won't delay getting to the experts any more than we have to. This series of models, we're hoping, is going to give you both evaluation portfolio view and implementation portfolio view, and a chronology of how the serious illness portfolio at CMMI has progressed over the last decade. So those are the goals of the discussion as described. So next slide, please. Our order of operations, we're going to start with the models that have been implemented and have evaluation findings, the Medicare Care Choices model, IH, and VBID Hospice. We're also going to be moving to the models that are announced or in operation. And starting with ACO Reach High Needs, we have 1 virtual presenter for that, and then Kidney Care Choices, and concluding with a model about to begin in Guide. So really excited for this presentation. We do know that this is a quick snapshot of a breadth of our portfolio, and we're looking forward to in-depth discussions in the future. Now, 1 more slide as we get started. We wanted to frame this discussion around the timeline of our models that are being discussed. On the y-axis, we have the type of model, whether it be a congressionally mandated demonstration or a CMMI model, and whether it's been completed, it's in implementation, or it's been recently announced, and of course the x-axis time. Independence at Home, as you know, has been in existence since 2012 and continued and all the way through 2023. The darker gray is for the completed Medicare Care Choices model. And for those models in implementation, VBID Hospice, we're presenting evaluation findings to date. But then for those models in operation, in orange, ACO REACH and Kidney Care Choices and Guide about to begin. So just wanted to set the stage a little bit further and give you a timeline for our portfolio. We are thinking this is just about chronological and wanting to help you see the evolution of our CMI models to date. And Angela, I'm happy to hand over to our first presenter, if that's okay. So I will hand the mic first to, we are very close to each other. I will turn off my mic in just a second, to Suzanne Wensky. And please, as you start your remarks, give a brief introduction so people know where you're coming from.
Sure, thank you. Suzanne Wensky. I'm in the Research and Rapid Cycle Evaluation Group, one of the division directors at CMMI. I'm going to be sharing with you our evaluation findings from the Medicare Care Choices model. This was a 6-year model designed to test a new option for Medicare beneficiaries to receive treatment for terminal conditions along with supportive care from participating hospices. And this is in contrast to the Medicare hospice benefit, in which patients must forgo curative treatment for their terminal condition. To be eligible for MCCM, beneficiaries had to have cancer, COPD, congestive heart failure, or HIV/AIDS, have a life expectancy of 6 months or less, and also not be enrolled in the Medicare hospice benefit. And at 6 years, over 7,000 beneficiaries enrolled in the model. Enrolled beneficiaries received assessments in care plan development, care coordination, pain and symptom management, 24/7 access to a care team, and counseling. Next slide, please. From the evaluation, we found that MCCM enrollees spent more days at home and were 15 percentage points less likely to receive aggressive life-prolonging treatment in the last 30 days of life. MCCM also reduced net Medicare expenditures by 30%, mainly by decreasing hospitalizations and increasing hospice use earlier in the disease trajectory. Enrollees and caregivers had high levels of satisfaction with the care they received under the model. However, despite these favorable outcomes, CMS was unable to expand the model due to low model uptake and low market penetration, which limited the generalizability of these results. Next slide, please. So specifically, only 5 participating hospices enrolled 46% of all MCCM beneficiaries, and 3% of all hospices nationwide participated in MCCM. Many Medicare beneficiaries were not eligible for enrollment because they were enrolled in Medicare Advantage, and many of the participating hospices were in markets with high Medicare Advantage penetration. Other factors that contributed to low model participation or withdrawal were that MCCM was a voluntary model. MCCM payments did not sufficiently cover operating expenses according to participants, and many MCCM hospices were affiliated with a palliative care program. Next slide, please. Of the hospices that were successful in enrolling beneficiaries, providing high quality care and reducing Medicare expenditures, they tended to implement a no wrong door referral policy, gain enrollees' trust, engage enrollees and caregivers in ongoing education, and gave enrollees someone to call after hours. Last slide, please. So although CMS did not expand MCCM, the model is a promising approach to transforming care delivery at the end of life. And palliative care and concurrent hospice care continue to be tested in other innovation center models such as ACO REACH and Kidney Care Choices model. With that, I will turn it over to David Nyweide to talk about the evaluation results for the Independence at Home demonstration.
Okay, thank you, Suzanne. I'm also in the Research and Rapid Cycle Evaluation Group at CMMI. And Independence at Home. I want to stress from the outset that Independence at Home was a congressionally authorized demonstration project, which means that CMS didn't have any control over its timeline or some of the key design and evaluation parameters of the demonstration. However, the Innovation Center was charged with implementing and evaluating independence at home, and there are some lessons to be learned. The key goals of IAH were to reduce total spending and improve quality of care for high-need, high-cost patients who were seen by practices that specialized in home-based primary care. And in return, those practices could earn incentive payments that worked a lot like shared savings in ACOs. Now, as you can see on the slide with the patient eligibility criteria, these were really sick patients. And the criterion I want to particularly draw your attention to is the last one, the hospital stay in the post-acute care. Next slide, please. What we found was that using event-defined eligibility was problematic for the demonstration and for the evaluation. And the reason is that if you start with a high-cost event like a hospital stay, what we know is that for most patients, they have a downward trajectory of spending after that event. And you can see that in the blue line in the graph. At the same time, the way that the incentive payments were set up with the target expenditures, they had an upward trajectory from a national cost trend from the prior year. And so that divergence in those lines became an issue when the evaluation looked at the IAH patient spending and matched it up with a comparison group that was a group of patients who looked very similar but didn't receive home-based primary care, and found that in 2019, as an example, there was no difference in spending between those two groups, and yet CMS paid the practices $11 million in incentive payments, despite not showing any reductions in programmatic spending. Now, we all know that setting target expenditures is difficult in any scenario. That's nothing new. And there were, in fact, 3 different methods used in IAH throughout the demo. But the problem with setting accurate target expenditures was compounded in IAH because there was a relatively small number of patients in each of these practices. And when you have small numbers of expensive patients, their spending tends to be more volatile. And so it becomes that much more difficult to hit your target expenditures accurately. Okay, next slide. So that issue of small numbers also was a problem for the evaluation. Throughout the demonstration, a median practice had 400 to 500 patients in IAH. For the demonstration overall, that number hit a high water mark in year 5 with about 10,000 patients. And then it declined thereafter, mainly because the practices switched to innovation center models. Now, that attrition in practices and thus patients was an even bigger problem for the evaluation, because even from year 1, the evaluation couldn't measure total spending at a practice level because the spending at that level was too unstable and unreliable. So it had to pool all the patients across the practices and measure performance in the demonstration at the demonstration level. And so it really couldn't, like I said, the attrition in the patients really just compounded the problems. If you go to the next slide, what we ended up finding as a result, over the first 8 years of the demonstration, there's 2 more to be evaluated. There were only 2 of those 8 years that had statistically significant findings. Now, it could be the case that those other 6 years also had reductions in spending if we had greater power in the demonstration. We just don't know for sure. It could be that the practices increased spending overall, or it could be that there was no difference relative to the comparison group. The main thing to keep in mind here, if you take a step back and you consider that the types of patients that were targets of the demonstration comprised about 4% of the Medicare population at large, they're a very small segment, and the practices in this demonstration, they targeted specifically these types of patients, and they had a difficult time reaching critical mass. If you want to design a model that looks a lot like IAH, you're going to have a hard time doing it if you use your accountable unit the size of a practice. You have to think larger. Next slide. Lastly, a word on quality. The practices in IAH were responsible for 6 quality measures. They could qualify for incentive payments if they met performance thresholds for any 3 of those 6 quality measures. And of course, they also had to spend beneath their spending target. And as you can see here, most of them were successful with meeting the performance thresholds for the 3 claims-based measures. They weren't as successful with the site-reported measures, and they may have been delivering the care associated with those measures, but we don't know because they didn't report it. But the point here is that they were able to meet their incentive payments by reporting or by meeting the performance threshold with the claims-based measures alone. All right, to wrap up, next slide, some final key points on design from IAH. First, avoid event-based patient eligibility. 2, you got to consider the size of the participating entities and the accountable unit. Larger is better. And finally, if you're going to use participant-reported quality measures, make sure that you tie that to the incentive structure of the model. And with that, I will turn it to my colleague, Julia. Go ahead.
Great, thank you. Hi, I'm Julia Driessen, and I am the evaluation lead for the center's Medicare Advantage value-based insurance design model. Next slide, please. So this model encompasses a number of components and has been in operation at the center since 2017, but I'm specifically going to talk about the VBID hospice component, which I know you heard about earlier and a little bit yesterday. It began in 2021 and was recently announced that it would be concluding at the end of this calendar year. And essentially, the thrust of this model is that it allows Medicare Advantage organizations, or MAOs, to offer the Medicare hospice benefit as part of their benefit packages. And that is in contrast with what happens outside the model, where regardless of whether a beneficiary is in a Medicare Advantage plan or is in fee-for-service, when they elect hospice, that becomes the purview of traditional Medicare. So for participating plans in the model, in addition to the Medicare hospice benefit, they were also required to offer related services, including palliative care and transitional concurrent care. And they had a fair amount of flexibility, the plans did, in terms of how they stood up those offerings in the model. They also had the option to offer supplemental benefits related to hospice. Another thing to note is that in terms of characteristics related to putting this into the Medicare Advantage setting, there was a phase-in of the network adequacy requirements as it pertained to hospice, but beneficiaries maintained their choice of hospice consistent with how it would have operated outside of the model. In terms of participation in 2021, the first year, we had 9 MAOs enter 49 plans into VBID hospice. And currently in 2024, we have 13 MAOs and 78 plans participating. The last 2 evaluation reports released for VBID in 2022 and 2023 included a separate evaluation of VBID hospice. So looking at those first 2 years of 2021 and 2022. Next slide, please. Okay, now, as I mentioned, there was a fair amount of flexibility in the model design in terms of how the model was operationalized. And so somewhat unsurprisingly, we saw significant variation in how the MAOs sort of stood up the various components of the model. So that would include things like how they formed hospice networks, the criteria that they used for establishing their concurrent care programs, and also how they designed their palliative care models. There's also evidence in the evaluation of sort of, again, this is early, but of a bit of a learning curve where we saw newer plans in the model report more substantial challenges, and plans that had some experience in the model in that second year sort of reported that those challenges had attenuated or subsided. Nonetheless, sort of things that came out as elements that both hospices providing care under the model and plans participating in the model continued to devote significant effort to included education of providers and patients about these new services to make sure they were delivered to the right people at the right time. And then on the hospice side, there was sort of continual mention in the evaluation of the effort associated administratively in working with plans. And for in-network hospices, there were concerns about reimbursement. Next slide, please. Moving on to an overview of the utilization and quality findings so far. In general, utilization of the component services of VBID hospice was lower than MAOs expected. Now to the right, you can see a table with some basic statistics on the first 2 years of utilization under the model. In terms of impact, the evaluation did not identify an impact of the model on hospice enrollment or hospice utilization patterns as of 2022, but they did identify an association between VBID hospice participation by a plan and a small increase in hospice care experience as captured by hospice CAHPS. In addition to the quantitative analyses in the evaluation also included interviews with plans participating in the model, hospices providing care under the model, and beneficiaries who received care under the model. And so one thing to note sort of in this setting for this meeting is that many recipients of palliative care under the model were actually not familiar with the term or the services that it comprised, but for those who were aware, they reported positive experiences with this component. Next step, please. Or next slide. In terms of thinking about the design takeaways from VBID hospice, I think it's relevant to kind of step back and think about sort of the full scope of what the model entailed. So it represented the first time that an entity other than traditional Medicare was offering the Medicare hospice benefit to Medicare enrollees. So it involves substantially new collaborations or collaborations in new ways between plans and hospices, and it involves developing and rolling out new services like transitional concurrent care. So those both create opportunities for patients at the end of life, but also have their own attendant sort of learning curves and time taken to sort of troubleshoot and get to a sort of a good place. Another thing highlighted by this model is sort of the inherent tension in design between wanting to be sort of prescriptive about the kind of essence or priorities of a model, while also offering enough flexibility that you're harnessing the fact that your participants often are closer to the ground and may actually have sort of closer knowledge around their specific enrollees' needs and preferences. And then finally, sort of going back to a number of the points that I made on the last slide, the notion here is that this was both a payment model and also sort of much more than a payment model. So I think it's important to understand the significant sort of operational lift behind the scenes to make it appear seamless and coordinated on the front of the house. And so it was also important throughout this model for there to be sufficient support for participants to actually let them get to a sort of a sustainable steady state. So those are my comments, and I think I'm passing the mic to Meghan virtually.
Thank you, Julia. Hi, everyone. My name is Meghan Elrington-Clayton. I'm the Director of the Division of Financial Risk here at the Innovation Center. I just wanted to share with you about the ACO REACH model, which is one of our initiatives to help address the needs of seriously ill patients within accountable care organizations or ACOs. The high needs population ACO type in the ACO REACH model is designed to facilitate high quality, high touch, tailored care to Medicare beneficiaries with complex health care needs. The high needs ACO type allows participation by organizations focused on complex, high needs beneficiaries in order to test whether provider-led entities can replicate the successful clinical approaches of PACE and similar models of care within a broader Medicare fee-for-service population. These approaches focus on interdisciplinary teams that emphasize preventive care and meet regularly to update patient care plans in response to changes in functional and health status. In addition, these approaches may aim to manage patients' care across all settings, facilitating smooth transitions between those settings and reducing rehospitalizations. Next slide, please. Importantly, the introduction of the high needs ACO track is innovative because prior ACO models have largely been population agnostic and focused more on experience and risk level. Certain pieces of historical or traditional ACO design, such as risk adjustment and population size, have been less compatible with the dynamic and high acuity profile of the sickest and costliest patients. To make ACO models work for a high needs population, we made 4 key design changes that I wanted to highlight. The first is to qualify for alignment, beneficiaries had to meet a minimum risk score threshold, have post-acute utilization level or mobility and frailty status. Second, due to their smaller panel sizes, the minimum number of beneficiaries required for high needs ACOs is much smaller than other ACO types, increasing to only 1,250 beneficiaries in 2026. Third, during the first 4 years of the model, the benchmarks for high needs ACOs are based on regional expenditures rather than a dynamic blend with historical expenditures, as is the case for our standard ACOs. This enables greater benchmark stability as high need ACOs gain experience under the model. Fourth, we incorporated a new modified risk adjustment model, the CMS HHC concurrent risk adjustment model. to better capture rapid changes in health status as patients become seriously ill. The model does this by using diagnoses from the current performance year as opposed to the prior year under the CMS HHC prospective risk adjustment model used in Medicare Advantage. It also weighs acute conditions more heavily than chronic conditions and demographics. Next slide, please. We have learned a lot about what high needs ACOs are doing to provide high quality care and how they are providing this care from talking with our high needs ACOs, their providers, and their patients. High needs ACOs have prioritized investments in primary care capacity, practice level infrastructure, complex care management, and enhanced primary care, including behavioral health and extended hours. They have made greater use of primary care advanced practice providers such as nurse practitioners and physician's assistants. Also, hospice use in some cases increased while other post-acute utilization was decreased, consistent with their efforts to improve advanced illness management and timely palliative care. Home-based touchpoints have been central for several of the ACOs' care model approach as well. In addition, we found that high needs ACOs are reaching more diverse populations than standard ACOs, serving a greater percentage of dually eligible patients and patients that are from racial and ethnic minority groups. You can learn more about the impact of high needs ACOs in the second annual evaluation report for the ACO REACH model, which we're expecting to release this summer. It'll be the first report to provide evaluation results for high needs ACOs due to their limited number and size. Next slide, please. We've also learned a lot about the considerations in designing a model for ACOs serving this population. For one, it has been a challenge defining the high needs eligibility criteria in a way that fully reflects these patients as well as the panels served by providers who specialize in caring for them. High needs ACOs have found it challenging to grow and to achieve scale given the size of their patient panels and mortality rate. We can see that they are delivering care that is tailored to these populations. So the question is whether there's a way to make sure these patients still have access to that care while ensuring that it's a viable model. The concurrent risk adjustment model has been tested for 3 years and has been well received by stakeholders. We are evaluating whether and how the concurrent risk adjustment model could be expanded for additional subpopulations and models in general. And then in terms of generating shared savings compared to their benchmarks, high need ACOs tend to perform better than other ACO types, which is somewhat expected given the risk adjustment and benchmarking policy are really designed to maximize their payment stability. However, we continue to explore whether the current incentive policy is appropriately balanced with net savings potentials for the model. With that, I'll now turn it over to my colleague, Laura Misset, to speak to kidney care choices.
Awesome. Thanks, Megan. I'm Laura Misset. I am the model lead for the Kidney Care Choices model and also was the model lead for the predecessor model, the comprehensive ESRD care model. Going to talk to you a little bit about KCC today. You know, this is a very sick population and we wanted to test KCC to see if that coordinated care ACO type structure could work for a kidney specific population. In this model, we are focusing on patients with chronic kidney disease, stages 4 and 5, ESRD and transplant. So we wanted to take the kidney care kind of from the whole spectrum. We aligned through the nephrologist in this model instead of the dialysis facility. So we can catch those beneficiaries more upstream, possibly before they get to ESRD or before they get a transplant. We have 2 different risk options in this model, and we have the CMS Kidney Care First option, which is a nephrology only option. So that is modeled after the primary care first model, where just nephrology practices can participate in that option. And that is a Medicare home style model. They're paid by a performance-based adjustment based on different quality results. And then there is the comprehensive kidney care contracting option. That is our ACO type structure. And we have different levels of risk for shared savings from, you know, the graduated level 1 option, where it's all upside risk, all the way up to 100% risk for shared savings and losses. We have three different innovative payments that we introduced with this model. So the first is the chronic kidney disease quarterly capitated payment. We've never had a capitated payment for this population before, and it was set at approximately 3 times of what a nephrologist would make normally in fee-for-service. This upfront payment is to account for things like technology and investments in the model, care coordinators, and things of that nature. We also have the home dialysis true-up payment. This allows for home dialysis to not be disincentivized. It brings home dialysis up to the same level of payment as you would receive for in-center dialysis. So it's no longer a disincentive for prescribing home dialysis. And then finally, we have the kidney transplant bonus. So this is a bonus on top of whatever you would normally be paid fee-for-service for a kidney transplant per beneficiary. It is paid in installments over 3 years to incentivize keeping that kidney transplant healthy for the duration of 3 years. And then you get that full $15,000 bonus. So that is also new in this model. We have approximately 130 model participants. About 30 of those are KCF practices, and the remaining 100 are KCEs, which are kidney contracting entities, which is just ACOs for kidneys. So we are at the halfway point in our model, almost exactly. We will be ending in December 31st, 2026. What we have noticed so far is that for the first 2 years of our financial results, we do use a retrospective trend adjustment in this model. And the retrospective trend adjustment was a little larger than maybe anticipated by our entities. And we find that to be a little unsustainable for predictability in the model and transparency in the model, because you're working towards one benchmark all year, and then it's not until after the year's over that you find out that that benchmark, the actual expenditures were much higher or lower. So we did incorporate risk corridors for the retrospective trend adjustment. They start in PY 2024, so they start in this year to help protect from some extreme retrospective trend adjustments. We saw with this model versus our predecessor model that there are more organizations, more care coordination organizations participating in the model than we saw. So it's not just dialysis facilities anymore in this model. It's also bringing in new investments into the market, and we see a lot more participants entering. The CEC model, for comparison, had 37 ACOs, and we have about 100 ACOs and 10 different organizations. So there's a wide participation, and people are excited about the model. Some of the challenges that we've had in the kidney models is difficulty in benchmarking. We're using this retrospective trend adjustment in this model. We used a reference population, which also had its own issues in the predecessor model. And like some of my other colleagues were saying, it's a small numbers problem. So it's a small population. It's difficult to meet the beneficiary level that's required to evaluate the model. We work with OAC to come up with these estimates of how many beneficiaries each entity needs to be able to evaluate the model correctly. And sometimes people don't meet that. So smaller entities can't participate as well. We also run into carving out certain procedures and medications and devices in this model. Particularly, we don't ding the entities for transplant costs. So we do take transplant costs out of the equation. We want to incentivize transplantation. And we're also looking at some of the TDAPA and TPONIs, medications and devices that are in the market, and if we should take them out of the benchmark or not, or incentivize their use or not. We do have issues with overlapping beneficiaries with other models. And, we think that once you have a late stage kidney disease diagnosis, that you're better suited for the kidney model. And there was a little bit of research to support that with the CEC model evaluation results. And another thing we have trouble with is accounting for quality of life and intangibles. For example, what's the price of someone getting to continue to work while they're on dialysis because they're dialyzing at home or at night? And what are those quality of life increases of staying off of dialysis in general? So it's hard to account for things like that in the model. We also have a couple of benefit enhancements for this population, the concurrent care benefit enhancement that allows you to continue dialysis if you're in hospice. That has been really popular. We don't have the exact the claims data yet. We're trying to get that, but we do have anecdotal evidence that people are using this, people like this benefit, as well as the kidney care education benefit, allowing more patients to get that benefit and additional medical staff to administer that benefit. So, all right, I think that is all for kidneys. We do have our first evaluation results will probably be released at the end of the summer. So please look out for those and send us any questions. Thank you.
Thanks, Laura. I am Tonya Saffer, and I'm pleased to join you guys today. I'm going to be talking about the Guiding and Improved Dementia Experience Model. I'm the division director for the Division of Healthcare Payment Models, and our division focuses on improving the quality of lives and care for people with chronic and serious illnesses. So a couple of the models mentioned here today, Independence at Home and the Medicare Care Choices model, were led out of our division. And now I'm pleased to talk about a model that we are launching very, very soon here, July 1, the Guiding and Improved Dementia Experience, which we call GUIDE. Next slide. So as I said, July 1, we're tracking to launch this model, and we'll test whether a comprehensive package of care coordination and care management, caregiver support and education, and respite services can achieve three primary objectives. The first, to improve patient living with dementia, or the person living with dementia's quality of life, reduce caregiver strain, and reduce or delay long-term nursing home placement. The GUIDE model requires that these services be delivered by an interdisciplinary care team that is at least made up of a clinician with dementia experience and expertise, as well as a care navigator. Next slide. So Medicare beneficiaries, we may have jumped ahead too quickly. There we go, eligible beneficiaries, thank you. Medicare beneficiaries must be fee-for-service enrolled, community dwelling, and not enrolled in hospice or a PACE program to be aligned to the GUIDE model. They do not need to have a prior diagnosis of dementia to be eligible for GUIDE, as we recognize there is a great amount of underdiagnosis of dementia, particularly in underserved areas. And we also know that there's a great deal of misdiagnosis. So instead, GUIDE dementia care programs will be required to use one of two validated publicly available tools to assess someone for whether they have mild, moderate, or severe dementia. And then scores for these assessments will be used to determine the level of severity, and they'll be placed into model tiers. Now we can go to the care delivery requirements. As I mentioned, the comprehensive assessment is the first step in a person living with dementia's path in the GUIDE model. The person living with dementia will also be asked to identify a primary caregiver. They will still be able to participate even if they don't have a primary caregiver. That caregiver, though, will be assessed for stress and strain.
And the 8 domains on this slide encompass that package of care coordination, care management, and caregiver support services that the dementia care programs under the guide model must deliver or partner to deliver. One of the unique features of this model is the availability of the respite services to help caregivers take a temporary break from their caregiving duties. This is the first time the Medicare program will pay for those services, and our goal is to see whether it helps move the needle on reducing that strain for caregivers and reducing nursing home placement. We will also attempt to collect data on caregivers who are enrolled in Medicare fee-for-service to assess the impact that respite might have on the caregiver's health and their use of healthcare services. Next slide, I'll talk about the payment methodology. Guide is not a shared savings or a capitated model. Instead, dementia care programs will receive a monthly dementia care management payment, which we refer to as the DCMP. The DCMP will be billed using G codes under the physician fee schedule that are tied to whether the person living with dementia has that mild, moderate, or severe status, and whether they have a primary caregiver and the strain of that caregiver, resulting in those different tiers for payment. That tiered DCMP will then be adjusted based on the performance of a set of metrics used in the model, and also adjusted a budget neutrality adjustment based on health equity. So we call that the health equity adjustment. And to qualify for that adjustment, that will be applied based on the percentage points of patient, or sorry, the percentage of patients that are dually eligible and living in a high area deprivation index. So that adjustment will be either plus or minus, depending on whether or not the dementia care program and guide is serving a high number of underserved beneficiaries. So the dementia care programs will be able to bill as well for the guide respite services, and that's annually. There's a cap of up to $2,500 per year per person living with dementia and that have a caregiver and are in the moderate or severe payment tiers. The guide model requires that all dementia care programs offer in-home respite, but they may also offer respite services in an adult day health center or an overnight facility. In addition to support new dementia care programs in underserved areas, we have provided a payment, or we will be providing a payment, one-time infrastructure payment for those that meet those qualifications. And my last slide on overlaps. So as we mentioned, guide is not a shared savings or capitated model, and instead was designed with the intention to be complementary to other models, and that includes primary care models. So as a result, guide clinicians and patients may also be participating in guide as well as another CMMI model or the shared savings program. That's my quick overview. There are many resources on guide on the CMS Innovation website's guide page, and I'll turn it back over to Suzanne.
Thank you so much. I'll be Suzanne's stand-in. I am thrilled that we have concluded a little bit early and have plenty of time for question Q&A and for this tour de force of CMI model presentations. You heard 3 unique models that have through the evaluation findings, and heard some central challenges in terms of our ability to evaluate models based on small numbers, challenges with enrollment, and other benefit design issues that maybe lead to variability for implementation. You also heard how we're trying to address this with our new ACO REACH model and changes to the risk adjustment methodology, the provider patient eligibility criteria, and also within KCC, what's happening with the concurrent care. When we say benefit enhancement, that's internal speak for specific waivers to CMI model authority. And then, and we are so excited for what's about to roll out in guide. So with that brief summary, I'm really excited for your questions, really looking forward to the discussion. And thank you again so much for the opportunity to present.
Thank you. Thanks to all the team. And I'll just say congratulations to you all. It's sounds like a lot of hard work, and you're fulfilling the vision of CMMI to innovate and try new new models of care and then bringing them forward and testing them, and appreciate you sharing all that with us today. And so I'm going to ask the PTAC members if they have questions to flip up their name cards and we can. Jeannie, I think you're first.
Thank you, everyone, for the presentation. That was incredible. This is a more general question, but one of the things we heard this time and in past public meetings was the timeline that these models have and the fact that they get cut at a certain timeline, because then it forces systems not to be able to invest for the long term and actually create sustainable infrastructures. So my question to you is, how would you how can that change, or how would you think about that? Because the investment is significant in order to be able to make this work.
I'll start with a quick answer since it's a general question, but then any of our panelists should feel free to weigh in. I think it's a really important question, and I'll actually say I think it's an even more important question as we start to work in spaces where, like our Making Care primary model or some of our Medicaid models, where we're working with providers who don't have a lot of experience in value-based care, so they need some ramp up time. And what you'll see is that we've actually extended the length of a lot of the models now. How long is GUIDE going to run for?
I was going to take that. It's going to run for 8 years.
Yeah. So Tonya, if you want to add anything else, but I think, there's two pieces to that. One is, what does it take for us to support with infrastructure payments and other things, providers to get ready to really succeed in value-based care? And then also, how do we help sustain what happens either through successor models expansion or just setting folks up for success in that? So we're thinking about both sides, right? How to get them on board, how to have the models be a little longer, and what the other part wants. But do you want to speak specifically to that in GUIDE, just because it's a great example?
Yeah, so GUIDE, as I said, will run for 8 years. And one of the reasons we did that is because we understood that there may be a long trajectory, particularly for the dementia population, in reaching, sort of end of life or long-term nursing home placement, which is a core objective of the model, is to delay that placement. So we realized we may not see that early on under a typical, 5-year timeline. So we have been thinking about that in our models, and it's playing out in GUIDE. So.
Walter?
Thank you for sharing all that information. That was really wonderful. The impetus for this whole public meeting is kind of the observation that Medicare spending is highly skewed. 5% of Medicare beneficiaries, those who are seriously ill with complex chronic conditions, account for over 40% of Medicare spending. I think inherent in that observation is a common challenge that I heard across multiple models, which is the issue with small numbers, right? 5%. How do you design care models that only address 5% of the population or 10% of the population? So I think one kind of answer to that would be, you find concentrations of dense patient populations within certain practices, oncology, kidney disease, maybe nursing homes, for example, of these seriously ill patients who are densely located, and you find practices that will focus on that to better incentivize their care. I guess another kind of thought I had was, are there thoughts of encouraging providers to focus on this population of patients? So what I'm hearing is kind of these models will encourage voluntary enrollment of practices that are kind of doing some of this, but not really encouraging them to focus more of their efforts and attention on this, rather than kind of easier fee-for-service patients.
I'm just going to make sure I heard the question, and then I welcome any of my colleagues to jump in. I think what you're saying is, would we or have we thought about sort of creating an incentive to be a specialist in the care of complex chronically ill patients? I don't think we've done that directly. I mean, I think we've more tapped into, as you said, places where there's concentrated need. And I think the other thing you see as you look at sort of the early evaluation findings into ACO REACH is how do we bring some of the concepts we're trying to build on into these broader care models, right? So an ACO has a much broader population, but we can build some of those kinds of needs into that. But I don't know if anybody else wants to add to that.
Try quickly just with, and just waiting for Mike. So just to say, as a longtime observer of this committee, the one of the recurrent themes we hear is sort of creating the payment structures and the clinical care following. At least I've heard that said today in previous conversations. And I think from a CMI perspective, I want to at least give an opportunity to make sure that David and Megan have an opportunity to speak on IH and ACO REACH. But we would think that some of the work that's been done to facilitate both the integration of these integration within an ACO construct, and then also the establishment of the high needs track within ACO REACH would encourage more clinicians to choose to care for these populations. At least that'd be my observation as an individual clinician. And I think David in particular can speak to some of the challenges in terms of having this be a unique model for this defined population. I will say one maybe under the hood feature of GUIDE that I think is particularly interesting is the proportion of the patient population that has dementia and that kind of dementia specialist that was included in some early conversations around GUIDE. So, so certainly I would welcome Tonya's comments as well.
I don't know that I have anything more profound to say, but I would say we were pretty broad in who could qualify as a dementia, and we say a clinician with dementia expertise, right? So we expect to see palliative care providers, we expect to see geriatricians, we expect to see primary care, generally internists caring for this population. And really what that expertise was based on is a number of factors. Have they cared for a certain percentage of their population with dementia before? Do they have clinical training in dementia? So there were a number of ways to qualify for that, which broadens the pool of the types of clinicians that can participate in care for patients in this model. I would love to hear David. He's going to go on mic. Okay, talk more about IH because he and I have had lots of conversations about the struggles of caring for these, high needs populations.
Well, the only thing I'll add is that IAH was specifically targeted toward practices that delivered home-based primary care. That was the solution to treating and caring for patients with high needs and high costs. An ACO high needs type of ACO wasn't that prescriptive. It said it allowed providers who wanted to treat and care for patients in any number of care delivery mechanisms, it allowed them in. There were a number of IAH practices that transitioned to ACO REACH for similar reasons. They thought it was more flexible and it provided an opportunity to care for a broader set of patients. So that's what I would add.
All right, Lee. Okay, Lindsay.
Yeah, thank you, Angela. Two questions. One, I think specific on the VBED hospice, and then one maybe a follow on to that. I think the first one is you pointed out that the utilization of the services was less than intended, expected, or whatever word you want to use there. My curiosity was around how would a patient or beneficiary or a primary care provider know that that MAO was participating in it? So I guess one question is, if we're thinking about making consumers in general, our patients, our providers aware of all of these different programs, how would they have known that they had this extra benefit available to them? And then I think maybe the broad follow-on in general is there's so many things, and some with some very specific benefits for the beneficiary as well. As you look at the guide with the caregiver respite services, I mean, that's huge. You think about the VBID and the ability to access things you can't. To what extent are the models considering how patients or beneficiaries know to seek out providers that are participating in these models and kind of shine a light on new things that are available to them.
Great. I'm happy to go first and talk about the Viva experience. And I think I had a bullet point sort of that was 1,000 words sort of on your exact question, which is, I think, on the ground, this notion for MAOs of how you educate the sort of vast network of providers, given that there are so many entry points to the potential conversations related to palliative care, related to TCC and hospice, was particularly challenging. Sort of one of those things that I think folks anticipated, but then the full magnitude really came out when it really was go live. So that was certainly a place, I think, where participants and sort of the team on this side of the house are still kind of working to troubleshoot and improve, because there is just such a vast array of how folks end up at the kind of right place and have that information and getting there. And there's also, I think, an awareness on the part of participants that they were very clear with us about, you know, the particular position they're in as a plan and wanting to sort of stay somewhat comfortably arm's length from a decision that really is more about the provider and the patient. So there's also sort of intentionally trying to be 2 degrees away and kind of capture the broad network of the ways folks may end up having that conversation. So it's more of a recognition of the challenge than the sort of solutions that we've figured out, but it is a place where at the frontier we're working on.
So to clarify, it was fully on the MAO to decide if and how much they chose to popularize to their beneficiary that this benefit existed.
Well, to some extent, so there was certainly a floor, right? So it was part of sort of the notice of coverage and other things in the sense that the way other parts of the benefit are, but in terms of how it was disseminated, you know, participants did engage in I think relatively intensive across the board kind of education efforts. That was one of those ways in which it did vary how they went about doing that and even sort of how they changed that over the course of the model.
And I can add for guide because I think we're doing something unique where we are trying and testing whether sending letters to beneficiaries directly that alerting them of the guide model and listing participating dementia care programs that are in their service area will actually improve uptake and connection to those programs. So that's something that's unique about the model that we are trying out. And I think the other, which is normal in all of our models, is that we do a lot of robust learning and education with the participants. So we have a whole group within the Innovation Center that their responsibility is for developing learning plans for providers and helping with even peer-to-peer based education. And so one of the topics in our model, and I know that this has been the case in other models, is peer-to-peer, what works, what's working in terms of outreach and education and drawing more people in to these programs. And, you know, I think on the ground, as Julia pointed out, the providers who are close to the patients or close to each other and know the situation might have the best solutions to pose to one another. So.
All right, great. Thank you. Appreciate all 8 of you being here today and just sharing all this great information. And so we're going to take a break now from 12 to 1 o'clock, and we'll be back at 1 o'clock Eastern time. Ask everybody else to join us back at that time. Thank you.
Produced by the U.S. Department of Health and Human Services.